So we have found cryotech vitrification with its many advantages and significant improvements over all prior methods to be a very efficient method of vitrification. Dr. Koyama, the father of this method, is going to talk about his technique to us in detail in his next lecture. So I would just like to share some special tips that we must remember while vitrification. Because almost all cryoprotectants are toxic, it is important to watch the duration of exposure to the final cryoprotectant carefully before plunging into liquid nitrogen. Minimize the volume of the vitrification solution as much as possible. This can be achieved by using a small diameter micropipette. Now, because the volume of the solution on the tip is too small, there is a danger of evaporation. If the vitrification solution gets evaporated, then the toxicity of the cryoprotectants will increase. To prevent this, it is important to plunge the cryotech into liquid nitrogen as soon as possible after loading. Submerge the cryotech loaded with the cells directly in liquid nitrogen by passing quickly through the damaging vapor phase. This will avoid chilling injuries. Now, we all know that high warming rates are much more crucial to embryo survival than high cooling rates. So keep the cryotech submerged in liquid nitrogen very close to your workstation and microscope. Keep the thawing solution at 37 degrees for at least 3 hours prior to the procedure, and very quickly submerge the cryotech into the thawing solution. This will ensure very high warming rates. Now, vitrification is a highly skill-oriented process, and close adherence to the protocol cannot be overemphasized. These methods are developed by scientists with years and years of painstaking research, and we must follow the protocol thoroughly if we want to achieve excellent results as reported in literature. Now, I would like to discuss vitrification as an approach to prevent OHSS. OHSS is a potentially life-threatening iatrogenic complication of IVF resulting from the extensive use of gonadotropins. A variety of preventive strategies have been adopted to reduce the risk of OHSS, but none of these methods have consistently demonstrated efficacy in preventing the syndrome, except for cancellation of the cycle before HCG administration. Although cycle cancellation is the most effective and safest approach, it is obviously frustrating and costly for the patients, and a second attempt at ovarian stimulation may lead to the same risk. Another approach to reduce the OHSS risk has been introduced, consisting of elective cryopreservation of all the available embryos and postponing the embryo transfer. Avoiding fresh embryo transfer minimizes further exposure to HCG and gives the patients a chance to conceive from the frozen embryos. Now, this is a paper looking at the same approach. They had 24 patients where they electively cryopreserved all the embryos, and they've reported a clinical pregnancy rate of 41.6%. So again, I wanted to look at our data to see if we could actually reproduce these findings. We had 20 patients from July 2011 to June 2012 who were identified at a risk of developing OHSS. All these 20 patients were counseled to postpone the fresh embryo transfer. So they gave their consent, and we cryopreserved, vitrified all their embryos. And in a subsequent frozen embryo transfer, we did the transfer, and we had on an average 12.4 embryos per patient. Number of embryos thawed per patient was 3.7. We had a survival rate of 98%, and we had a clinical pregnancy rate of 66.7%. And most importantly, none of these patients developed severe OHSS. So obviously, this approach works extremely well in our hands, and it is a very effective method for selected women undergoing IVF who are at a risk of developing OHSS. Now, gentle stimulation protocols, known as mini IVF or minimal stimulation IVF, have been thought to produce less eggs, but eggs of high quality and be easier on the patients. Many studies have evaluated the efficacy of mild, low-cost, minimal stimulation protocols paired with vitrification. Now, this study comes from Dr. John Zhang's group. They mainly perform minimal stimulation at their center. So this is a retrospective data analysis of patients. A total of 202 patients from all age groups underwent 249 single embryo transfers, resulting in 43.56% clinical pregnancy. So their results have demonstrated that very favorable pregnancy rates can be achieved for all age groups with gentle stimulation paired with vitrification. This is another paper from the same group where they have compared the results of minimal stimulation with fresh embryo transfers and frozen embryo transfers. A total of 1,503 single embryo transfers were performed. And they found that when they used minimal stimulation with fresh embryo transfer, they had a clinical pregnancy rate of 20%. But with minimal stimulation and frozen embryo transfer, they had a clinical pregnancy rate of 41%. And the authors concluded that milder approaches to IVF give lower pregnancy rate per started cycle if only fresh embryo transfers are considered. And minimal stimulation is unthinkable without a reliable vitrification program. Now, women with a poor ovarian reserve who commonly do not respond to heavy stimulation are left with few options when planning a family. One such option is embryo banking with a minimal stimulation IVF protocol. This approach allows women to have consecutive cycles before the follicular reserve is depleted. It will maximize the ovary's already limited lifespan, allowing patients the opportunity to store embryos while oocyte production is still active. Results suggest the efficacy of this approach for patients who would normally be counseled for donor egg IVF. We have been practicing minimal stimulation with embryo banking since past 2 years. So these are our results, Rotunda results, reporting the cycle outcome after embryo vitrification and accumulation, AccuVit, in low responders with minimal ovarian stimulation protocol. The inclusion criteria were patients less than 44 years old and with at least one previous controlled ovarian stimulation cycle with poor response defined as less than 4 mature oocytes. We had 7 patients, and for these 7 patients, we have done 19 cycles, so an average number of cycles per patient was 3.68, and in these 3.6 cycles, we collected 4.8 embryos for them and vitrified these embryos in these 3 cycles. And subsequently, we transferred 2.4 embryo per patient, and we have an ongoing pregnancy rate of 42.9% in this group. Now, these are the patients where 3 or 4 embryos that we get are very, very precious embryos. We have to try all that we can to ensure that we get pregnancies out of these embryos. So a very, very efficient vitrification program is extremely essential and critical to minimize embryo loss. So in conclusion, on the basis of all the best available evidence, it is clear that vitrification is superior to slow freezing for all stages of embryo development. Elective cryopreservation of all embryos by vitrification gives excellent pregnancy rates in subsequent frozen embryo cycles, and it completely eliminates the risk of severe OHSs. Embryo banking with a minimal stimulation IVF protocol is an effective way of completing families for women with poor ovarian reserve who would otherwise have to go for donor egg IVF. So we have a very efficient method and right protocol for vitrification now available. I do believe that it is an extremely powerful tool at our disposal, which is changing the way we practice. And we have to ensure that we use this tool to its fullest potential and offer an extremely efficient IVF program to our patients. Thank you.